Good afternoon, everyone. I'm Cory Busse. I'm the Vice President of Strategy and Sales Enablement here at Icario. Thank you all for joining us this afternoon. I'm seeing some participants kind of trickle in here at the top of the hour. We're going to give them just another moment before we jump in earnest and into the full content. But wanted to welcome all of you on behalf of Icario and Rex Wallace Consulting to this webinar on the key insights and actionable strategies for health plans on 2025 stars, navigating 2025 star ratings. A couple of housekeeping notes before we begin. One, because inevitably the question will come, we will make this webinar available to attendees on the back end. So look for that as a component of your registration. That will accompany the slide deck that you're about to see here as well. In addition, we'll utilize the chat and the Q&A for the Q&A component of our discussion at the bottom of the hour. So if you don't mind, as you're contemplating questions that you want to ask, please capture them either in the chat or in the Q&A, ideally in the Q&A, and we'll field them either as we go, or we are reserving time at the end of the webinar for a dedicated section of Q&A. With that, let's jump in. Just a quick overview of what we'll cover today. We've covered the welcome. We're gonna take a moment to take an assessment, a quick assessment of what has already had an awful lot of ink spilled on it already with respect to a breakdown of what occurred with 2025 star ratings. We'll talk about the economic and strategic considerations for health plans, particularly in this segment of the government space. We'll provide some steps that plans can take even as soon as right now in order to contemplate what the practical application of this sort of consulting and advice should be with respect to how to navigate the existing environment or the 2025 environment for stars. And then, as I mentioned before, we'll open it up to a broader question and answer. We've had a couple of questions come in already from the pre-registration, so we'll address those. But as I mentioned before, please use the Q&A. We're happy to address those questions in the bottom part of the hour as we go. But first, before we get too far into it, I've introduced myself. I'd like to turn the focus on our subject matter experts here for the remainder of the hour. A couple of friends of ours here at Icario, first Rex Wallace and then Dr. Bob Mirsky. Rex, if you would take just a moment and introduce yourself, please.
Yeah, thanks, Cory. Hey, and thanks for partnering with us and having us on today. I'm excited to be on and talk about 2025 stars. So I'm Rex Wallace. I lead RWC. We're a quality improvement consulting firm, serving health plans around the country. A lot of Medicare Advantage clients from a stars perspective. That's a heavy part of what we do, though we do also focus on Medicaid and marketplace and kind of all things quality within a health plan. So health equity, provider engagement, the whole 9 yards. So yeah, excited to be here today. So thanks, Cory.
Thank you, Rex. Welcome. And thank you for jumping in with us this afternoon. We're excited to partner on this. This quickly is especially on the heels of the release of stars. Excited to be right on top of it. And I will turn to our friend, Dr. Bob Mirsky.
Hey, good afternoon, everyone. It's great to be here and to discuss this very timely topic. I am a family physician by training and practice. I spent most of my career on the health plan side, provider-owned plans, blue plans, all segments. Most of my career was in the Coventry Aetna CVS world, most recently as the Chief Medical Officer for Aetna's Medicare business. And that was from 2014 through 2020. And now I help to support Icario, and I'm excited to be here today.
Bob, thank you for joining us, and welcome to not only the webinar, but to Icario. We're excited to have you and your contributions going forward. So let's jump in. Rex, I'm going to turn to you first and foremost. We've had an opportunity to do some prep work on this together over the course of the last couple of weeks as we've digested the news and the headlines from what occurred with star ratings 2025. But for the purposes of level setting for everybody both here and on the call, give us a sense, if you could, about what actually occurred, what happened, and the key takeaways from the actions that CMS took with cut points in 2025 stars.
Yeah, I think it's safe to say that a lot of plans woke up and got punched in the face, right? In when they got their star ratings, and then when we got the public star ratings, here in the last few days, yeah, there were a lot of surprises. We knew, we knew cut points had changed more than they ever have. So we knew it was a hard year. But now that, all the data is out there in public, I can say confidently that it was the hardest stars year ever. And that's saying a lot. Because we've had some challenging years, but never one with as many, impacts as this one. So it's reflected on that top line there, right? That's the average star rating, and we see it decline. We knew it would decline from 2022. That was right, the COVID relief year. Everyone got the better of, and everyone, you can see, there were 74 5-star plans, many more than we'd ever had before. I think 21 was the most we'd ever had before, until that year. So we knew things would be declining, over the next 2 or 3 years. The 5-star plans declined down to 57 in 2023, which is that far right column, and then down to 38. So, at least I expected that 38 to fall down into the 20s, right? Because again, before COVID, 21-ish was the most we'd ever had. I can tell you pretty safely that no one expected only 7 5-star contracts. No one expected, I don't think, the average star rating to fall down below 4.0, down to 3.92. Those are really significant drops, and we'll definitely get into a little bit more of, some of the reasons why, on the next few slides. But that's at a really high level. But yeah, what would you guys add to this?
Well, I want to keep you on that for just a second, because I do think that dramatic drop, particularly from 2022, which itself was an anomaly, right? To 2025. For the majority of the folks on the call are obviously in MA plans around the country. What's the key takeaway? What's the key lesson that you might take from the fact that on the whole, plan performance actually improved year over year by about 3% at given measure levels, but overall star ratings continued to fall. Is there crystal balling or wisdom in that, Rex, that you have that you want to share?
Well, there's a little bit of this thing called Tukey in the guardrails that's hidden in there a little bit, right? So even though industry performance went up, when CMS calculated the cut points, they applied Tukey. So and to kind of backtrack to 2024, Tukey came in. Tukey had a huge impact on the cut points. And the way CMS originally wrote the regulations was, in the first year, these guardrails that had been put in the year before Tukey, these guardrails, which are designed to keep cut points from moving up or down, for most measures, more than 5 points, right? And CMS said, the intended purpose of having guardrails was because plans were asking for more predictable cut points. They didn't want these huge swings year to year and be unable to project their revenue from their quality scores. So CMS implemented guardrails to keep the cut points from moving more than 5 points. Then the next year, in 2024, they implemented Tukey, which removed all the outliers before cut points were created. And when you remove outliers, most of them are on the bottom. It makes especially the 2 and 3-star thresholds rise way higher. So we're talking like a 30-point increase in some measures for a single cut point year over year. But CMS lost a lawsuit because they didn't explain in the regulations very well or put in the right places of how those guardrails would not apply in that first year. So CMS had to recalculate the 2024 star ratings with the guardrails preventing Tukey from having a very big impact in that first year. Tukey still applies every year until it's and unless CMS changes its mind and puts in rulemaking that Tukey will not exist. So for now, Tukey was going to have a big impact in 2024, but then CMS lost a lawsuit, had to apply guardrails that really compressed the impact that the guardrails had, or that Tukey had. So in 2025, Tukey still is trying to make up this big difference, right? So it's got nothing to do with industry performance. It's got more to do with a few outliers that are still causing Tukey to have a significant impact. It's just compromised by the guardrails, but it's still and something else hidden in there is that some of the measures, because they were changed, like controlling blood pressure, guardrails didn't actually apply to that. So Tukey had a full impact on that, and cut points moved like 8-9%. And most people did not catch that measure would be allowed to move more than 5% this year. So that's and that's a triple weight measure. It moved a lot more than people expected and caused a pretty big hit to HEDIS scores. That's just a few of the things that are sort of hidden in there. There's a lot more, but I'll get way in the weeds if I go deeper than that.
Tukey and the Guardrails was ironically the name of my first band in college, by the way.
Yeah.
So, I'm sorry, go ahead, Bob.
Yeah, so listen, for me that's pretty in the weeds, but I also understand there are people on the call who are into the weeds, and the weeds matter. So, but I like to sometimes, kind of pull the aperture back a little bit. We'll kind of, go zoom in and zoom out. So for me, zooming out, right? And we can get into this a little bit more later. All of those things led to what you just described. But also, I think overlying all of it is that Medicare Advantage, the budget for Medicare is being stressed by Medicare Advantage, increasingly stretched by Medicare Advantage. And so we're talking about the sustainability of Medicare, and just looking from the CMS perspective, they're trying to manage the expenditures into Medicare Advantage, right? And that conversation may be a little bit for another day, but I don't think that it's accidental or happenstance that things have gotten harder, not only to get your stars, but also to get the revenue associated with stars. There's difficulty in getting the revenue associated with risk adjustment as well, and there are constraints on the tools for medical cost. So it's getting challenging from both a revenue as well as a medical cost perspective. But looking here, the other thing that really strikes me is, look, when I was at the plan, we would have loved to have had a few contracts that were 5 stars, but that was not the overall goal or where we put our resources. Where we put our resources was in getting our plans to 4 and 4.5 stars. And so, as you can see, those have gone down, but maybe even more existentially concerning is the number of plans that are moving into the 3.5 stars range. And, that's pretty awful in a single year, but over multiple years, that could actually compromise a health plan's ability to stay in the Medicare Advantage space. So we'll uncover a bunch of that, but, it's like a barbell, right? We're seeing things happen on the 4.5 and 5 star side, especially on the 5 star side, but also on the other side, we're seeing an increase in 3 and 3.5 star plans. And that is at least as concerning.
I think a lot of folks who, are joining this webinar, who have had occasion to hear from some of us on at conferences, on the conference circuit over the last few years. I know one of the things I've been saying is, as a watchword, that CMS was sort of destined to move in this direction. That and the way that I had put it from the podium over the course of the last couple of rises, if you will, has been CMS can't afford all these winners, right? And I think we're seeing some of the changes enacted through CMS rulemaking or rule application that is resulting in exactly, Bob, what you just said with regard to the increasing number of 3.5-star plans. Before we leave this slide, I just want to circle back, and Dr. Mirsky, you're the one who kind of prompted this thought in my head. I'm seeing more and more marketing from more and more health plans here as we're in the annual enrollment period. And the way that I will casually refer to it is 4 the new 5? Is 4 stars the new 5-star plan? Kind of in keeping with what you're saying, Dr. Mirsky, about the fact that, you know, if 5 were the goal, or even if it weren't, and 4 was it all along, at least from a marketing perspective, it feels like 4 stars is kind of the new gold standard, or is the new Cadillac that in most markets, because there aren't 5-star plans in most markets, that's being touted as and upheld as sort of the paragon now. I'd be interested in your thoughts on, as we're in AEP and the advent of fewer 5-star plans, the sort of the requisite value of your 4.5-star plans as we're courting members into those spaces. Rex, I see you nodding.
Yeah. You know, I said we expected, you know, in a 5-star plan, the count of 5-star plans to be in the 20s in, you know, this year. But if you would have asked me, you know, imagine we're sitting 2 years from now, you know, in October of 2026, and we're looking at everyone's 2027 star rating, I would say that number is going to be 0. So the 5-star plan, I think it's fairly safe to say that it's going to be a dinosaur. It's going to be, you know, somewhat extinct, unless other things change the way, but because what we're not seeing yet, and the reason this was surprising to fall down to 7, down in the single digits, is because there's one really big change coming, and it will apply in 2027 stars when the reward factor will go away and the health equity index will replace it. It's not a replacement because it's not nearly as impactful for most plans as the reward factor. But the reward factor, and again, not to get too in the weeds, but it is a bonus that high performing plans get. And virtually every 5-star plan, you know, in the last few years, everyone for 2024 stars, and I think 2025 stars, every 5-star plan had to get the reward factor to get 5 stars. Otherwise, it's a 4.5-star plan with just this big reward factor. That reward factor is going away, and most of these 4.5-star plans are not necessarily eligible for this new health equity index yet. So all that to say, 5 stars is pretty much going away until something else changes. So yes, Cory, to answer your question in a long way, 4 and 4.5 is definitely the new 5. It came earlier than we expected. I'm curious to see what it's going to look like in 2020. The 2026 stars, right? There's one other piece to this, is that there are, you know, I don't know, 14 or 15 measures that are member experience measures for most plans, and those are weighted really heavily right now at a weight of 4. That's actually, and they've been like that for I think 3 straight years, right? That's actually a big reason why there were 57 5-star plans in 2023 and 38 in 2024, because plans that are good at member experience and that were good in stars already, they really got a big boost from all of a sudden the no change in performance, but these measures I'm really good at all of a sudden are weighted heavier than any other measure. And their score jumped, you know, 30, 40 points. So they jumped into 5-star territory for the first time ever. Not to take anything away from them. We have some clients who are completely in that bucket. They've been high performing forever, but unable to cross into that 5-star threshold. They were finally helped by that big weight increase in those member experience measures. And I say that because next year, those measures are dropping back down to 2, and that will hurt a lot of high performing plans. That will cause them to drop 30, 40, 50 basis points on their score and could easily lose half a star or even a full star. So lots of reasons, and it kind of backs up what Bob was saying earlier, right? Like Like CMS is making it harder. There is a limited, amount of funds to pay for quality improvement. They've already paid more than they expected. This recalculation they had to do in 2024 made them have to pay 1.5 billion more than they were expecting. So every change they make in the regulations is measured in the regulations by the financial impact it's going to have on the Medicare Trust Fund, right? Like that's how they measure it in the regulations. So they're not implementing changes for the most part, any of them that are just going to help our scores get higher. They're constantly making it, more difficult. They're retiring high performing measures, implementing new measures that are harder to achieve. The whole thing is it's a Darwinian test, right? I mean, you have to continue to adapt to survive. So yes, long story, 4 is the new 5.
Yeah, and I'm, just adding, look, if there are 7 plans around the country that are 5 stars, you don't have to compete with them in almost every single market, right? So from a comparison basis, if you don't, you're unlikely to have a 5 star plan in your market. So you don't need to compete against the 5 star plan. From an optics perspective, from beneficiaries who are choosing a plan, right? But also from the plan side, well, why are we worried as a 4.5 star plan about a 5 star plan in our market? Well, it's because they can market all year long and they can take membership away, right? And so if you don't have someone that can do that, then the interest in competing in that realm or trying to get to 5 stars, becomes greatly diminished.
Yeah, and particularly in an environment where I think the number is 3/4 of all new members are going to one of 2 large multi-line carriers in MA. That becomes it becomes a really big factor for those remaining 7 who can compete all year long. Let's move on into some other trends. Rex, I'm going to come back in your direction here to talk just a little bit more about some of the other underlying trends that we saw as a result of these big changes in 2025 stars.
Yeah, just so this chart on the left, this is a couple of other indicators that we look at every year that are very reflective of industry performance. So the light green bar is the percentage of members, Medicare Advantage members, in 4-star plans and higher. Typically I would say, and again, 2022 is an anomaly because of COVID relief, but typically, that percentage is around 75% or so, right? 75, and like it was the last couple of years, right? 72 in 2023, 76 in 2024. And the reason that 74 is highlighted, that's I mentioned a reforecast last year. So CMS originally came out with one set of scores for everyone and then had to recalculate them for everyone. So the original percentage was 74%, but when you look back at the recalculation, the new number is 76%. And some people will see both numbers in different reports they're looking at, so I just wanted to show both. But huge decline this year, right down to 62%. That's very significant. That's a huge drop. So 62% of members are in a 4-star plan or higher. That is largely driven by and I don't know if I should name plans or not, but a couple of nationals, right? One in particular took a huge fall, had a really rough year. And both of those nationals are, have lawsuits right now against CMS, right? So that's another discussion, but there are there's a high number of lawsuits right now from plans challenging these results from this year. So the dark green bar is the percentage of members in 5-star plans. We already saw the 5-star plan count fall down to 7, so we knew this would drop. It's normally 5 to 10%, and it actually fell down below 2% this year. It's actually the lowest it's ever been. So that 2% is the lowest percentage of members in 5-star plans that we've ever had in Star. So, big big drops, surprising drops. I think it's safe to say no one expected them to drop that much, right? We knew in the next couple of years they would continue to decline, but not necessarily that much this year. On the right side, and LPI and HPI, this is the low performing icon and the high performing icon. A couple of other things, if you look at the fact sheet that comes out that accompanies star ratings every year. And one thing that jumped out at me here was, last year, 2024 stars, we had 7 plans that received the low performing icon. That means they received less than 3 stars for 3 straight years. So they get a warning icon on their next to their name. They're put on this low performing icon list, and if members enroll in their plan, they get a letter from CMS saying, "Are you sure you want to enroll in this plan?" You're right. Like it's a scarlet letter, right? On your name, and you don't want it. There were 38 plans that got the high performing icon. That just means they received 5 stars that year. So huge difference, right? 38 5-star plans, 7 on the low performing icon list. This year, those numbers are the same. We still had 7 plans on the low performing icon list, and we only had 7 plans that were on the high performing icon list. So it's just unusual, right? And I guess at least we have some balance, but not the balance that the plans are looking for. Some quick indicators on those 7 contracts that did receive 5 stars. None of them are new. They all received 5 stars last year. So no new entries this year. That's also not usual, not typical. 6 have a DSNP PBP in their rated contract. So I think that's surprising to a lot of people too, right? Because DSNP populations are more difficult. They're more difficult to reach and to help receive high access to care, etc. 6 of the 7 are for profit. That's not surprising necessarily. For-profit plans perform higher from a stars perspective than not-for-profit plans. 5 are 10 plus years old. Not surprising, because it's a proven fact that the more mature a plan is, typically the better it performs. There are some exceptions, because the other 2 are actually relatively new, less than 5 years old. And we've had clients who received 5 stars less than 5 years. So it's rare, but it can definitely happen. But the norm is that more mature plans receive the 5 stars. All were 5 last year, and Elevance was the only parent org to have more than 1 contract. Everyone else, Highmark, Leon Health, Network Health, Alignment Health, and MCS Advantage were, 1 parent org, 1 contract, but Elevance had 2, HealthSun and Optimum Healthcare. So, but no Humana, no United, no Kaiser, no CVS, right? No, none of the other national players are on that list for the first time in a while.
Hey Rex, if I had to plot out 2026 stars on the right-hand graph, would you agree it's more likely that the red bar will be higher than the green bar? Because the red bar is probably going to grow and the green bar is probably going to shrink. So that's a pretty dire warning as well.
Yeah, no, I think it's a great point, and I would say that. Yeah, I agree that maybe for the first time, right? I haven't looked at those specific numbers, but yeah, I think there's a very good chance that the red bar could be higher in 2026 stars. 2026, the member experience weights drop, which could hurt high performing plans and actually could help low performing plans that maybe perform better in HEDIS and maybe pharmacy or something, but not as well in member experience. So those measures won't hurt them as badly. But yes, I could see the red bar still being higher.
Let's talk about cut points and their impact in just a second. But I want to stay on this for just a second. Bob, you and I were exchanging some stuff earlier this week relative to the number of members who will suddenly and without warning find themselves not only no longer in a 4-star plan due to the fallbacks, but in 2 million members cases out of a plan altogether because of the contraction that we have seen in this market. and they're going to have to find a new plan. Talk a little bit about the risks and opportunities with that kind of contraction or consolidation in both membership and plans.
Yeah, I think it's going to create a very, you know, interesting situation, and I don't think it's a one-year phenomenon. I think it's going to be a many-year phenomenon. And actually, I feel like we're kind of here not only to alarm people, but also to help people mitigate, this kind of situation, right? Because I think not only are all the dynamics that we just discussed occurring around cut points and measure, all of that stuff, but we also know that when you acquire new membership, right? So membership's going to be exiting plans. They're going to be going, it's going to be a jump ball, right? And those individuals are either going to go to another plan within their original health plan, right? Another contract, or they're going to be going to a new health plan altogether. That health plan is not going to have a lot of insights into those members, at least not anytime soon. So now you're going to have all this new membership in addition to your incumbent membership, challenging you to understand what's going on with them from all different directions. Like, what are their medical conditions? What are their behavioral health conditions, social determinants of health challenges? How engaged were they? All of this stuff is going to be, kind of mostly unavailable. And the claims and other experience you're going to need to manage them is going to be slow to mature. So I think the additional challenge there is going to be that you're going to have like essentially new to you membership, right? As well as new to Medicare and new to you membership, making it more and more difficult for you to get your arms around your membership and what you need to do for them to help improve their outcomes, as well as their STAR scores, right? So I think anything you can do to learn about them as quickly as possible is going to be absolutely critical. And to learn about them, engage them as early in the year as you can, so that you don't like get into a situation where you're checking a box at the end of the year, and then a year or two down the road, you realize that all of this medical cost risk and STARS risk, kind of all flow together to create another perfect storm of plans becoming less solvent, and then kind of repeat that unfortunate cycle. So I think one of the things that we can discuss is how to engage more of your members sooner, to get them to complete health screenings and all of these different things, to improve their experience as early as possible in the cycle, but also to do as many health risk assessments as you possibly can, not as a by the end of the year kind of exercise, but as early in the cycle as you can, because then you won't have to only wait for claims to mature. You can get information directly from them and address those concerns. And I think in particular for DSNPs, right, where you want to implement your model of care, stratify your membership, and do your outreach, the more information you have, the sooner you have it that's usable and actionable, the better off you're going to be.
Hey, Cory, if I can jump in, you asked us in one of our prep calls when we were kind of talking through some of the stuff, right? You asked, hey, what's the what will be the most important innovation for plans to have in 2025?
Yeah.
I think it's that, right? I think it's understanding your members as deeply as you can, right? In new ways. So, and to all the points that you and Bob made around, I think I think the number is maybe 2 million members are in a contract that will terminate. Some number, I think like 700,000 of those will be crosswalked into a new plan automatically, so they won't have to physically re-enroll. But 1.3 million members will have to physically find a new plan that has their providers in it, that covers their medications at a low cost, right? That covers their conditions, that everything, right? Like it's and these are members with chronic conditions with lots of medications. So because and these are members from mostly low performing plans that are exiting or closing these PBPs, at least, right? Low performing plans. So these members are probably not, high scoring members right when you first bring them in. So to Bob's point, like that early engagement, whether it's through HRAs, welcome calls, focus groups, consumerism data, like anything you can do to understand them more deeply, especially not even to mention like the impact that'll have on your ability to influence the health equity index that's coming down the line, right? For if they are eligible for the HEI. But yeah, that will be, I think, the most important thing that plans will do, especially if they're taking on these members, is understanding them quickly and not letting them, not letting those members' characteristics that they're bringing from their prior plan sink your plan, right?
Right. Yeah. Just a couple other stats on that too. I think it was Kaiser Family Foundation reported that member acquisition costs top $2,000 for each member.
Wow.
And as we know that, and that's just acquisition, right? We know that on average, MA members don't become profitable to a plan. And I know it's taboo, don't talk about profitability, but members don't become profitable to a plan until year 4. At the same time, C26 members choosing to leave the plan ticked up to an average of 17%. 17% average voluntary member attrition. They didn't die, they didn't move. They picked somebody else, not you. And so all of those factors coming together with respect to member retention, acquisition and retention, become critically important to exactly Dr. Mirsky about what you're talking about. It's desperately important to understand these members so that you can engage these members, so that you can keep these members, because the economics of not doing so have just gotten that much more expensive for health plans. Let's spend just a couple of minutes on this. This is one of the highlights, and this is an additive component, Rex, that you threw on top here regarding the number of plans in the overall MA ecosystem.
Yeah, it's a little bit of what we just talked about, right? So just to hammer it home, it's the same graph as before, but yeah, like Cory said, it's just with the total number of contracts layered on, which actually climbed, right? Like new entrants have been frequent in the Medicare Advantage market, right? I mean, we have more than 10,000 members, 10,000 people a day, right, turning 65 and entering the Medicare Advantage eligibility arena, at least, right? So it's largely been seen as a product line that health plans cannot avoid, cannot be out of, right? So yeah, you've got to have a Medicare Advantage product, but it's hard, and this was the hardest year ever, and we actually are seeing that number go down, and buried in that, between that 545 and 521. So there's a mix of new plans that were added and plans that exited, right? So the plans, the contracts that are no longer here is actually 34. I'm sorry, 58. So it's so 58 contracts, 58 contracts were eliminated and 34 were new. So, but focusing on those 58, right? That's where those 1.3 million members sit, right? So some of those are obviously really big contracts with Humana and United and CVS, I think, but where where a lot of what we just talked about needs to happen if you're one of the plans that picks up some of those members. But the point here is just, the decline for the first time in a while of the number of Medicare Advantage contracts, and I think it's a little of what we're going to see for the next few years. I think we're going to see more and more. We're going to see consolidation. We're going to see, because, some of the ability to survive, not all of it, but some of the ability to survive is having some scale and being big and having influence over providers. Clearly, it's not the silver bullet, but it's something that helps a lot of plans perform more highly. So as plans merge, smaller plans in some fashions are going to exit, be forced to exit, right? Because they can't influence the kind of care they need to have.
Yeah, and I would just add, the largest plans, the big national plans, they do have a lot of resources that they can shift around. The smaller, more regional plans, some of the blue plans are incredibly resource constrained, maybe don't have as long of a history of having all of the components to orchestrate within stars. I think it's important to know like what's in your wheelhouse and what's in other people's wheelhouses, right? So, now that I'm with Icario, I would suggest that there are things that we can do at scale, right? Where you may not have scale that will help you free up resources to do the things that you need to do so that we become part of that orchestration and that virtual team for you. So I think that will be a critical thing. And I think we have a lot to offer there. Just one quick thing. I saw in the piece from the Better Medicare Alliance this morning that actually there are more DSNPs,
Yeah.
this year or in 2025. That's actually growing. And so, look, these SNPs are just a wonderful thing to, in a coordinated fashion, take care of some of the most deserving members who are dually eligible. And, there's a fair amount of financing that goes into that from CMS that will help to weather, some of these ups and downs. But I would also suggest that it's also now going to get even more competitive. And so you want to have every advantage in understanding your membership and implementing programs that are going to improve their outcomes and all of the adjacent spin-offs from improving patient outcomes, member outcomes. For me, like doing all of that, especially in a DSNP environment, stars almost becomes a bit of a byproduct. Not that you aren't focused on it specifically, you are, but the more you take care of people holistically, the more of a halo and a salve you put over all the measures that occur when you coordinate care, help people get needed care, take care of behavioral health, social determinants of health challenges. So there's a huge opportunity to do all of those really great things, and then the blocking and tackling stuff underneath that we can also be a part of.
Just in the interest of time, I'm going to move us forward. We've talked quite a bit already about the impact of cut points. Rex, you talked about Tukey, guardrails, cut points, etc. This is from our friends at Baltimore Health Analytics. So thanks to Jeff Schoenborn and his team for this graphic. But this is you can see the blood in the ledger here, right? The red here indicating all of the cut points that increased in 2025 compared to 2024. And the expectation that all of the basis that Rex outlined before about the dropping of the weighted factors and caps might have both a negative impact on those that have relied on those cap scores to stay where they are, and a positive impact on those who maybe could use the boost at a lower weighted average. My question is a little less to that and more something that we talked about previously this week. With regard to all of that and the movement that we've seen in these cut points, is it your sense, Rex, that does CMS have any inclination or interest or appetite to sort of self-regulate, to self-modulate? It's been a very tough, litigious year for CMS. It will continue to be with additional lawsuits.
It's not over.
Pending, right? The reaction to stars this year has, as we've just discussed, resulted and will continue to result in continued contraction, compression within the market, creating maybe the unintended consequence of fewer choices for members. Do you see that reaching the upper echelons of CMS to the point where they will maybe take the rulemaking action that you suggested before in order to say, okay, the savings that we've recognized, I'm going to flip ahead and kind of give away the headline here. The $14.7 billion that CMS has saved in QBP by some of these reductions, that's good enough for now, or should we expect more?
It's a great question. And just, I clearly don't have a crystal ball, right? But I would say I think the next couple of years are baked, right? I mean, we have regulations that have already passed through rulemaking that are going to change the member experience weights, that are going to eliminate the reward factor, that are going to implement a health equity index. All three of those things will have material impacts on STAR's performance, and for the most part, all will make it harder. So the next 2 years will continue to look like this year, I believe, right? Hard and drops in scores and loss in QBP and and plans exiting the market. Now after that, as again, there are some big lawsuits in play right now. We don't know how they're going to play out, but um and there are I expect more lawsuits coming, right? There's no reason to think that more plans won't sue for things, not only with the fact that CMS did lose the lawsuit to Scan, um, but the fact that the Chevron doctrine changed, and not to get into the weeds, but they don't have as much, you could argue they don't have as much power as they had before to be able to determine what and any ambiguous regulation says, right? So they're losing some power, they're losing some lawsuits. So I mean, I do think it's possible they could come back and find themselves having to make some changes that are 3 and 4 years down the road. It'll have to go through rulemaking. But yes, I mean, I could see that. I don't know that that'll happen. And even if I was like sitting at a, roulette table, or I don't know how I would bet on that, but it's definitely a possibility, Cory. Yeah, with everything they're facing right now.
Dr. Mirsky, your thoughts here?
Yeah, and I think the horse is going to be well down the road by that point, right? A lot of the consolidation will have happened. And so any sort of loosening that would happen would likely accrue to those bigger consolidated plans. I don't think it's necessarily going to help the smaller plans 3, 4, 5 years down the road. So that's why I think, I think what we're hoping to focus on here as a takeaway is like handle your business now, right? Because if you're hoping for something to change, the pendulum doesn't swing wildly from year to year. It will come back in some form or fashion going forward, but by that point, it could likely be too late. So you want to be, if you're, mid-sized plan, regional plan, whatever it is, you want to be taking these actions now. I think you're, those plans are at a bit of an advantage in some ways, knowing their membership, having good relationships with their members and the providers, taking advantage of that now, and then doing all the blocking and tackling you need to do to hit your mark on all the different star measures.
And I think to some degree they don't have a choice. I think they are doing what you're saying, Bob, because we had a client say in a meeting just the other day, she said, with all of these changes, that are in place now and that are coming the next 2 years, it's impossible for a Medicare Advantage plan to have a 5 to 7 year strategy, because you don't know what it's going to look like. It's going to change and you just don't know how. So all you can do is focus on today, and plan for the next 12 months maybe. But and I think she made a great point. I think um if we had less change, it would enable more of that forward looking um strategy, right?
But to that end, what are some things? Because I feel like we need to inject that ray of sunshine here, because we've been we've been a little dire consequence here.
This is where we say we can all help, right?
This is where we can help. What should plans be thinking about doing, taking action on? What's the back to the office takeaway for this afternoon that plans should walk away from this session with this afternoon?
Well, yeah, I can start, and I would say, from a stars perspective, right? Yeah, it's I don't know. I encourage stars leaders to um take a little time alone, right? Like really think. Like we find ourselves in back to back to back meetings. I do myself, even all day, every day, from 7 a.m. to 6 p.m., right? And there's no time to think. So carve out time to really think about your plan, your challenges, what you need to close out this year. This is an incredibly important year. It's the last year of the reward factor. So if you are close to 4 as a projected score, the 4 star, the threshold to get a reward factor will probably be just below the 4 star threshold again this year. So, you if you're high 3.5, you have a chance to get 4 with a reward factor, or 4.5. So like, understand understand how that's calculated, understand it's based on variance and mean, and have your analysts focus on, hey, what specific measures are hurting us in the reward factor, and which ones are going to help us, right? So really, inward thinking, inward looking to develop a plan for your specific contract with your specific challenges. And then, then it's all about organizational engagement to me. It's getting your cross-functional partners on board. It's building trust with them, right? It's getting them in a room in person and building trust and getting aligned on our objectives and goals. And because if you don't build trust and you don't align on goals, you will never be able to execute. So you have to do those two things first, right? So that's a little bit what I would say.
Yeah, and listen, I tend in my speaking to weave solutions in all along the way. So I would just sort of go back to in addition to what Rex was saying around the different things you need to do, I'd say just broadly, right? Get to know your membership as quickly and as early as you possibly can, and get them the needed care they need through your programs and through providers. I think that's going to put a salve on all of your measures. People are going to get, their gaps in care closed. They're going to have, better access to healthcare and health equity. All of the different things, all the virtuous things happen when you understand and know your membership, you engage them in a sort of cross-functional fashion and get them to the appropriate care settings, and then work with your providers to make sure that everything gets done in those care settings. And, I saw a question, before that we were being asked. I'm not sure if this exactly is the question about MSOs, but to the extent that you're a payvider of some sort, a provider-owned plan, a risk-bearing entity, or a plan working with risk-bearing primary care practices, connecting the dots between what the plan does in concert with what the providers do. The more you can orchestrate that, I think the better the outcomes are going to be, and it will express itself not only in STARS performance, but it will express itself in better medical costs, because you will have done more preemptory work with your membership as opposed to having things happen in a more emergent fashion. So Cory, that would, again, the HR, to me, like one of the things I've been most excited about with Icario is getting HRAs done at volume, at scale, as early as possible, looking for the actionable information in there, and then working with plan partners to take those actions as quickly and as early in the year as you can.
And that is very much, I give the advice to plans all the time that, and Rex, you touched on it with regard to getting partners within the organization, cross-functional partners aligned, because what we tend to do is assess what's wrong with a member, and then there is a period of time that goes by, and following the assessment, we analyze the data that we get, another period of time goes by, and then we enlist a program in order to address what we found. And it's often months-long gaps divorcing what we assessed from the action on which we're taking that we're taking on it. And I would encourage much more closer proximity between the assessment and the action, because we deal very much in what I refer to frequently as the finite and knowable. The things that our members tell us that are, to Dr. Mirsky's point, not knowing our members doesn't necessarily mean that we don't know what they're going to say. It's finite and knowable. The list of things that prevent members from getting care or taking meds or seeking help, we all know them, we all experience them, we all work within them every day. So they are finite and knowable. And so concocting the remedy in concert with the assessment is tantamount to success, and getting to know members, as Dr. Mirsky suggests, and getting connected, like Rex suggests. I'm a strong advocate of connecting quality and risk as closely as you possibly can, because those two P&Ls, when they exist in silos in health plans, don't do either of them any good, and then tend to work at cross purposes with regard to competing for budget, as opposed to coalescing around a singular goal where rising tides raise all boats. Let me put a period on that and open up the Q&A. I'm not seeing additional questions in the Q&A, but for folks who may have joined late, at the bottom of your screen, there should be a Q&A button about third from the right. Please add your questions to the Q&A, and we'll respond to them in turn. One of the additional questions that came in the lead up to this conversation was, if I recall, related to future cut points, 2026 cut points, and I think we've addressed that quite a bit here. I think it is the hard answer is it's too soon to tell, right? So we don't yet have a view or a prediction of what cut points specifically will be, except to say that, as Rex suggests from earlier in the conversation, they will almost certainly go up for all the factors that we've seen, including largely the removal of guardrails, which will see, potentially even higher increases than we saw this year. So as 24 winds to a close and we get into 25 and get some visibility into the proposed and final rules, for example, and some additional thinking that might predict the math of cut points in 2026, we'll get closer to a true prediction with some specificity around those cut points later in 2025. So when we do, you can bet that we'll maybe have another one of these to talk through what those might be.
Hey, Cory, I know some people, may not have asked questions, but have been percolating on this. Is there a process where they can ask their questions sort of post-webinar, and then we can reach out to them and, have an additional conversation to, get their questions addressed?
Most certainly, yes. And there is, you're always welcome to contact us at Icario or at Rex Wallace Consulting, utilizing either the registration materials that you received in order to do this. There was a way to submit there, I believe, Q&A from that. In addition, the website at icariohealth.com will allow for folks to ask questions. Rex, is there an inbound sort of question format that you've got on your site as well?
As far as an address?
Yeah.
Not really. It's just Rex.
Email Rex.
Rex Wallace Consulting. Yeah,
What's funny about it is most people can just do that. They know you well enough that they can.
Yeah. And I would say really quick on cut points too. Our team is always thinking about cut points. So, we there are some reasons to believe that, a lot of the HEDIS measures increased a lot this year, up and bumped up against the guardrails. There are some reasons to think that they might not do that next year. However, it's really important to understand, the outlier impact with Tukey on each of these cut points and which measures the guardrails will and won't apply to. So there are a lot of nuances in cut point assumptions and projections, and we think about that a lot. So feel free to reach out if you want to discuss those.
Well, all right. We're coming up on the top of the hour, and seeing no questions in the Q&A or the chat, we will leave it there. Thank you, everyone, for your attendance today. Dr. Mirsky, Rex, thank you for your participation this afternoon. Always a pleasure talking with both of you. We hope that you took something away from today's presentation, and as Rex suggests, please feel free to reach out with any follow-on or additional questions at the conclusion of this webinar. Thanks again. See you next time.
Thanks, Cory. Thanks, Bob.